Good afternoon, ladies and gentlemen. We're ready to call to order the Rutherford County Benefits and Insurance Committee. And you have received a copy of the minutes from the last meeting. Do we have a motion? Motion from Ms. Hickerson, a second from, all right, Ms. Barnes. Did anyone have any corrections or additions? If not, all in favor of that, then please say aye. Aye. Any opposed? All right, that's good. Now we're have financial report from June and July. Mrs. Stinson.
Yes, sir. If you will refer to Fund 264 reporting, we will begin with the end of fiscal year for June 2012. Our per employee per month for June was $726.96. That's compared to prior year of $770.67. When we add in our on-site medical clinic experience, our total per employee per month goes to $762.15 compared to prior year of $820.32. We ended up at 10.6% overall in trend for fiscal year 2011-2012.
Okay, you're going to just go on, or we need to approve those. Can we do those concurrently together, Ms. Anderson? Okay.
Moving on to the month of July. For the month of July, we have a per employee per month of $918.84 compared to prior year of $773.71. When we include the clinic experience, we go to $955.92 for the month of July compared to prior year of $791.34. This month we have a 20.8% increase in trend.
And Ms. Benson, would you want to give them any explanation regarding?
Well, there's a couple of factors if you look at this report that would contribute. Just comparing the self-funded claims from July of this year to prior year, we're almost up $1 million. We're at $4.5 million this year compared to $3.6 prior year. So that's one of the contributing factors. The other is the billing process within our clinics. As you can see, as you review the reports, the months kind of wax and wane. There's no consistency in the billing month over month because we review our contracts on an annual basis. So costs for our clinics for this month, or for this year in July, were $189,453.48 compared to prior year, which was $87,850.80. We were also at that point in a run-out period with Care Here, so we had reduced our ordering to try to not have as many supplies and medications on hand at the time that we switched the contract, so we would have seen some of their costs go down as well during that period. We will have premiums from the Board of Ed start to be counting again, and of course that always affects our numbers as well. So it'll really be a couple of months before we start seeing what our true trend is running. 1 month is just not enough considering these factors.
Okay, are there questions of Ms. Stinson regarding this report of these for June and July? Ms. Stinson, let me ask a question. I mean, I may be not seeing something here, okay?
Yes, sir.
I'm seeing it all now. I just wasn't looking. The self-funded claims, that first column of 4.5 million, that's where the big number is, isn't it?
Yes, sir, and that's our Cigna claims. Those are the claims that passed through.
Cigna claims now, which in July of last year it was 3.6, but in August of last year it was 5.1. So it's just sort of a reflection of you can't predict what 1 month's going to bring.
That's correct. And we had a couple of different factors. We had a large claim in the month of July that we paid out over $500,000 on one particular claim that we may not have had the prior year. So there's always those anomalies inside of the plan that you will see the numbers jump from one to another. Of course, it's, people on vacation patterns, those, seasonal illnesses, things like that, always those contribute to what the plan will see within a given month as well.
Okay, anyone have any questions? If not, we need a motion to approve the financial report. Sandvig and Mr. Hester second. And now, any further questions or discussion? If not, all of you in favor of that, please say aye. Aye. Any opposed? All right, that was approved. Now we're ready to hear about workers' comp and OJI.
Okay, if you refer to Fund 266, we'll do the same and start with the month of June. Closing out the fiscal year, we're at $535,792.26 compared to year-to-date of $972,976.98. Moving on to the month of July, we are at $74,775.16 compared to prior year of $62,887.82. There is an additional sheet for the OJI reporting this year, or this month. It is from Select Actuarial Services. I had shared this with our Budget and Finance Committee last month as well, and I think it's important information for you all. One of the most common questions I receive is how are we trending inside of our OJI compared to what we would be had we remained in workers' comp. Every 2 years we have Select Actuarial do an audit and actuarial service for our OJI program. The sheet in front of you shows that based on their projections for July 1st, 2012 through June the 30th, 2013, our OJI program will have an ultimate loss experience of $586,000. Had we remained in a workers' compensation arrangement, our cost would be $2,049,000. So there's a significant difference in what the two programs would have realized during this period. So I thought this would be helpful information for you all as well.
All right, does anyone have any questions regarding the report on workers' compensation and combined with OJI? We still have a few workers' comp claims that will be with us
Yes, sir.
going forward even for a while, and I guess some forever since they're lifetime benefits on some of them, I suppose.
Yes.
Any questions from anyone? That's an excellent outcome, and it appears that the benefits that we're providing under OJI must be reasonable, because I haven't had a single complaint about how we've administered the program or how it's been effective in taking care of their needs of our employees. What's your response from the employees?
Well, we have, on occasion, we will receive an appeal on a decision that will ultimately generally lead into the second appeal process. Typically, those circumstances are outside of the plan document themselves. What we have not seen is a trend in those appeals that suggests to us that we need to make any significant modifications. It's typically been some extended period of time that's elapsed since their last claims activity or something of that nature. And in some instances, we have actually received information back that they've determined that the circumstances that they originally appealed for had changed. So we do monitor that to see when we do need to modify the plan to make it good for the county and good for the employees.
Okay, any other questions or concerns? We don't have to approve this report, that's just for their information. Is that correct, Ms. Anderson? Okay. Wellness update is next on the agenda that I have here. Is Mr. Good going to give us a report, or have we sort of skipped over that, or is that included?
No, sir, that's a separate report Mr. Good provides.
Should that be included right now before we move to number 4?
That should be actually number 3 on your agenda list. Financials includes OJI and the...
So your financials was not in, okay, was...
Yes, sir.
All right, so Mr. Good, I was a little bit off. She gave the financial reports on workers' comp and OJI, but you're going to tell us about the actual
Yes, sir.
occurrences, et cetera.
You'll have 2 reports in front of you. The first one is for the month of June. Notice in June of 2012, we had a total of 8 injuries in the county requiring medical attention, bringing the total for the year to 93. And then on the other side of that, you'll notice that the total recordables were 71, restricted days 34, 11 lost days, and 26 others. If you go ahead and turn over a couple of pages, what I wanted to do in the month of June, being that June ended the first 6 months, in June I reported for the first 6 months of the year, and that's what you're going to see here continuing on. You'll notice, like I said, for the year there were a total of 93 injuries. The total dollars incurred for those were $273,300. When you break that down for the first 6 months, the county general had a total of 33 claims for a total dollars incurred of $155,563. The Board of Education had a total of 59 for the first 6 months, and the total dollars incurred for those was $117,736. And then lastly, the Highway Department had one, but there were no dollars assigned to it at the time. Go ahead and return over one more time. You'll notice that reporting for the County General, I was asked to break this out at one time by department, and the 33 claims for the first 6 months, you'll see the breakdown there on that last page by division or department within the County General. Are there any questions on the first 6 months and on June? Okay. The next report you have there in front of you is reporting for the month of July, and that's, of course, the 7th month, so I'm just going to be reporting for the month of July. We had a total of 10 injuries, bringing the total for the year up then to 103. Again, you're going to see the total recordable, 77, 38, 12 for lost claim days, and 27 for all others. Of the 10, you'll notice that eight of them were for the County General, and for that month, the total incurred dollars were $6,300. The Board of Education had 2 for the month of July, and they totaled $1,150 for total incurred dollars. And then those 8 on the last page of that report, that's the breakdown within the County General for the departments. Are there any questions on the report, on either report?
Not along here, then. That's a good report. You don't see anything we should be concerned about?
Not at this time, sir.
All right. All right, then. Very good.
Thank you.
Thank you. Wellness update, Ms. Kelly.
Good afternoon. I'd like to give you the wellness report for June and July. I actually have combined my numbers together on this report. We have started a new program this summer, Wellness on Wheels, where we come to the people's individual departments. We've done 7 programs servicing 20 county general departments for June and July. We had attendance of 87 people out of 153, and our outcome results are listed below. We had a participation rate of 57%, which was really exciting to us because we feel like people are interested in participating in the wellness and they are interested in seeing the outcomes of their health. They just need us to come to them. So we're very encouraged by our participation numbers. Our wellness discount for the past was Julie Wiscoxkin. She's a certified personal trainer. She had 12 Rutherford County teachers go through her boot camp 6 weeks and complete that, and over 100 Rutherford County employees subscribe to her summer fitness guide. The second page shows your angio screen summary that we conducted in May. We had 73 participants. We had 53% of our participants had abnormal and pre-hypertensive blood pressure ratings, and 18% were shown to have hypertension. 75% were found to be overweight or obese. And on our Wellness on Wheels, we found people with 51% had abnormal good cholesterol levels. Since those results of the angio screens and the Wellness on Wheels, we are going to try to encourage people to exercise more. Those are the That is the main thing that we can do to help the blood pressure and the cholesterol levels. So we are going to kick off Walk Across Tennessee, September 10th. Your flyer is the third sheet. So we would love if you would post that in your department and pass that information out. For the individual wellness coaching at MedPoint, we have 6 new open cases between May 19th and 31st. There's 16 active cases with a 50% return rate. So Walk Across Tennessee, September 10th through November 5th. The person that logs the most miles is going to get a Nook from Barnes & Noble, and each team member will get $25 gift cards. We have a cooking class set up at the Rutherford County Health Department on September 20th at 5, and our wellness fair is set for October 12th at Lane Agger Park from 3 to 8. Anybody have any questions?
And I'd like to just make a couple of comments here and have you interject as appropriate. On the Wellness on Wheels, just for the committee, we have received some very positive feedback from employees. Employees are taking their time to send individual emails of appreciation to Ms. Perrin about the program as well. So we've been very pleased with the results that we have seen with the Wellness on Wheels. Could you just elaborate for the purposes of the committee, give them an idea of how many hours you're spending, as well as you just attended the DI conference for the Board of Education, and maybe you could talk about the response from employees there on Wellness on Wheels.
We did attend the DI conference. It was July 31st and August 1st, and I'll report those numbers in August. The Wellness on Wheels is what we're doing is just coming with some health tips, as well as doing a cholesterol screening, a non-fasting glucose, blood pressure, and this August we've also added a DermaScan machine to the table. So just help our employees increase their awareness about their individual health. They get their results in 7 minutes that day. We provide education, handout, information about stress release and stress techniques, and just increase and promote participation in the actual wellness program. And we're hoping in September, we're trying to get into central office as well as the sheriff's department. So we would like to visit each school and just grow the program.
Typically there like a couple of hours to allow the schedules of individuals to accommodate your being there. Is that correct?
We have a Cholestech machine and the glucose machine. It takes about 8 minutes a person to do the test. So we're saying 3 to 4 hours depending on the staff size at our site.
And once you get these results from these cholesterol, et cetera, what are we recommending that they do to follow up on some of these that might need some improvement?
What we are doing is if we see anything if anybody has a result that is not normal, then we are referring them back into the MedPoint clinic to see a physician, and we're giving them education of how to change their cholesterol levels or better lower their blood pressure.
I think it's important to note as well, and correct me if I'm wrong, but Lori Cook, who is our wellness coordinator, who actually is employed through Take Care and is part of the MedPoint clinics, is actually doing the Cholestech. Is that correct, Ms. Perrin?
Yes, ma'am.
So she has the ability to go back and share the information, the results with the Take Care staff. So we don't have a breach of HIPAA or anything like that because she is an actual Take Care employee. So that allows them to engage and come up with ways to reach out and address our employees' health concerns.
That is correct. I'm staying out of all of the numbers. I'm personal HIPAA. I'm mostly working the education and helping enroll the appointments. Lori Cook is scanning all these results in the MedPoint patient files when she returns.
That's a good report. I mean, I think one of the overriding objectives here is to identify those things that we might need help with and put a plan in place to help correct those before they become more difficult and more serious. So it's preventive. Okay, thank you very much. Now we have update on payroll deductions. Are you handling that, Ms. Stinson?
Yes, sir, I am. Mr. Gammon had requested at our last meeting that we review the opportunity to have deductions for insurance taken twice a month rather than once a month as they currently are. We had a meeting between risk management staff, finance for both the Board of Ed and County General, and HR for both Board of Ed and County General as well, to explore the opportunity for the deductions being taken twice a month. Ultimately, where we landed was what is the needs or the desires of employees. Because as we talked through the different options, what kind of came to light is that people have personal budgets, and what we don't want to do is to make an executive level decision without engaging employees in a survey process so that we can get their feedback and then do what is the request of the majority. So Ms. Stevenson and Ms. Barnes were charged with putting together a survey that will go out in January of 2013. And from that survey results, we will then take the action that best reflects the desires of the employees. So what will be incumbent upon us is to make sure employees participate in the survey so that their voices can be heard and we can make the decisions that they want us to make. So we will give a follow-up after the January survey is conducted. And based on that, the deductions will actually begin 2014 rather than 2013, should it show that they want the deductions taken twice a month instead of once.
Any feedback from anyone else? Ms. Barnes and Ms. Stevenson, is that about where we are?
Did I state everything correctly? Okay.
Okay. Midpoint Patient Satisfaction Survey results. Mrs. Stinson.
You'll have in your packet a copy of the survey results. Take Care Health System uses Sullivan Llewellyn, who is the leading healthcare customer service consulting firm in the U.S. They specialize exclusively in healthcare, working with both large and small physician practices and provider networks since the 1980s. They were actually charged with putting together a patient satisfaction survey for us to use within our MedPoint clinics for the first quarter of this year, so that would be January, February, March. So we could actually gauge our employees' utilization of the clinic and their satisfaction level related to that. The database for Sullivan Llewellyn contains nearly 360,000 individual patient responses, representing 53 medical specialties, and that's important for later on in the report. So if you will actually look at the report, we'll just walk through it. There are different categories that a patient would respond to following their appointment with MedPoint. One of those categories, as represented on number A, is your appointment. It asks questions of ease of making the appointment available within a reasonable amount of time, did they receive care and service timely, the efficiency of the check-in process, waiting time in the reception area and the exam room, and keeping you informed if your appointment was delayed. The overall score with a 5-point scale for our group was 4.41, so we received 4.41 out of 5. The national database at Sullivan Llewellyn is a 4.36 average, so we actually ranked a little above average based on their database. The next category was the staff, the friendliness and courteousness of the staff, the care and concern of the staff, the skill and professionalism of the staff. In that category, we ranked 4.71 out of a 5-point scale with the national database score of 4.62. So again, we ranked above the average. The communication was the next category. Phone calls and emails answered promptly, getting advice or help when needed, explanation of any procedures if applicable, the test results reported in a reasonable amount of time, and usefulness of our health information materials. We ranked a 4.48 out of 5 with the national database score of 4.43. Your visit with the clinical provider, the willingness to listen carefully, take time to answer questions, amount of time spent with the patient, explaining things in a way that could be understood, instructions regarding medication follow-up care, the thoroughness of the examination, advice given to you on ways to stay healthy were the topics in this category. We ranked a 4.63 out of a 5-point scale with a national average of 4.65. The facility. Hours of operation convenient for you, comfort of the patient waiting area, comfort of exam room, and cleanliness of facilities. We ranked a 4.35 out of a 5-point scale. There was not a national database score provided in this category. The overall satisfaction was also scored of the healthcare facility, service, health improvement as a result of services, likelihood of returning to the facility for medical care, and recommending the facility to the coworkers or friends. We ranked a 4.5 out of the 5-point scale. The patient demographics for this survey were primarily male, with 67.4% represented in the survey results. Males represented the balance at 32.6%. The average age for taking the survey was 31 to 40 years old, representing 26.2% of the survey results, with the second category being 51 to 64 years of age, representing 25.10%. The employee status represented 75.3% of active employees took the result, with the employee dependents, active employee dependents being the second highest category at 20.5%. Overall, we were very pleased. There was a free form area that they could complete, and that's what I provided you by clinic attached to the survey results. I can tell you that the transition was very difficult. You all have heard those comments made by me up here before. I feel that we would have gotten different results had this survey been done in September when the contract was taken over. But in the short period of time in which the contract changed to take care in the time in which this survey was done, and the number of complaints that we receive in our office at this point about the clinics is very, very, very minimal. I am very pleased with the work that Take Care is doing, and these surveys show that the employees are as well.
How many people did you say was in the national database?
In the national database, there's over 360,000 individual patient responses.
A large sample of people
Right.
there. Okay, and you can read through these comments, and there are, well, one of those at the bottom of that first page said she had problems, or he or she had problems making appointments earlier in the year, could not get one, had me scheduled an hour appointment. Things are much better now, so.
Right. Part of that too, though, on the hour appointment was all new patients have an appointment for an hour, their first appointment. And that was new to Take Care. With Care Here, every appointment, regardless of why you were coming, was a 20-minute appointment. So that was a little bit of an adjustment that caused some pain to our employees. So I think that we have finally worked through that now that we've established patients inside of our clinics.
Those of you that are using the clinic or your employees, are you getting the same sense of satisfaction? Seemingly yes. Okay, good. Anything else on that, Ms. Stinson?
No, sir, I just wanted to provide that.
All right, thank you very much. All right, someone will have to tell us about TCHS, the first quarter 2012 business review.
That would be me. So each quarter, Take Care provides quarterly reporting, which I introduced you to the fourth quarter not too long ago. So I'd like to provide first quarter 2012 reporting for you. During the first quarter of 2012, some of the key accomplishments, I won't read these all, but I will touch through, is basically in our Stewart's Creek clinics. The hours were increased, and we opened every day for walk-ins. That has taken a lot of the complaints about availability of seeing a provider off of the table. I rarely ever get a complaint like that, if ever, since we have made that change. We also started the process of recruiting for Ms. Cook, who has now joined us, and we initiated the patient satisfaction survey. Within this report, we can probably skip a couple of pages because we've touched base on some of this information already. If we'll move on to number 5, the total encounters within the clinics were up by 10.5% from the previous quarter to 3,168 compared to the prior quarter of 2,866. Acute respiratory infections continue to be the highest diagnosis compared to previous quarter. The net savings continue to exceed the original feasibility projections, and we'll talk about that a little later. The top 5 diagnostic categories by quarter is the upper respiratory tract infections, general symptoms, hypertensive diseases, preventative services. I was very pleased to see. We've seen a significant increase in those services this quarter compared to last. And acute respiratory, as we mentioned before, was also our highest disease state that was treated. Moving to page 6, the clinic saw 2,840 unique patients during this quarter compared to the last period, which was 1,965. We achieved a 23.7 penetration rate of eligible population compared to prior quarter of 15.6. We do continue to see an increase in our provider visits. Our ancillary visits continue to increase. Those are where you don't have to see a doctor or nurse practitioner. Those are medication refills, labs, things of that nature that are taken. One thing that I do want to mention to the group is that one of the attractive qualities of Take Care during the bid process was our expansion into retail. We have began that review process, and I will report back to the insurance committee on those findings as soon as we've completed our review. Page 7 walks us through the net savings summary. These are direct cost and indirect cost avoidance figures. One of the numbers I'd like to point out in here is the total emergency department cost avoided was $45,600, and we have a case study in the back that I can kind of give you an example of what would calculate into that. The overall net savings for quarter 1 was 67% higher than projected at $177,671. We had $284,147 in net savings realized, which is a variance of to the model of $177,671. So I can tell you that Take Care calls me and talks to me frequently about what their experience is from a financial perspective, so I know that they are monitoring the contract and monitoring the expenses inside of our clinics. Program trending. This just basically shows us, who are we reaching inside of our population. I provided you statistics in the past that shows that because of the limited hours of our clinics, we are only able to reach a certain amount of our population. That's what we hope to avoid with the retail clinic model, and be able to have extended hours and more locations that patients can be treated above what we have today. The demographics, as I've mentioned earlier, for this particular quarter, we saw the most patients between the ages of 50 to 59, with the second highest category being 40 to 49 years of age. And those are the individuals that we also have seen, if you turn to the next page, the increase in the preventative services. General symptoms, as noted on this page, includes headaches, cough, and fatigue. The preventative services are screenings for unspecified conditions, hypertension, diabetes, our GYN services, and routine medical exams. Those aged 30 to 59 contributed the most in the top 5 diagnostic categories that we mentioned previously. Continuing on with program trending, looking at the top labs by quarter, we have the CBC, the Comprehensive Metabolic Panel, the HDL, triglycerides, and cholesterol. And what's not included in this is the services that the Wellness on Wheels. This is actually done inside the clinic, so I don't want you to think that the Wellness on Wheels is feeding this report, because that's separate what Ms. Perrin has provided. The last page of the report, I referenced earlier about the ER avoidance cost. We had a patient come into the clinic presenting with a shortness of breath, lower extremity edema, so increase in fluid. And what we found was we sent them on to a cardiologist where they were evaluated and treated for congestive heart failure within 3 hours of presenting to the MedPoint Clinic. Those are the type of success stories that we don't always get to hear about. But that was an ER cost avoidance, and probably was very helpful to the employee as well, because they didn't have that continuation of the disease process had they not presented to the MedPoint Clinic. There's also 2 other examples on here that talks about an individual had uncontrolled diabetes and hypertension. We have actually gotten them into the endocrinologist and the nephrologist, and we have that patient now stabilized. These are all savings to us within the plan, because uncontrolled circumstances is what's driving some of our health costs, which is why the preventative services needs to be given in a way that people will respond to, and I think that we saw that with the angio screen services. What we know now is that we have to go to them. And we are designing programs to do that. This is a very abbreviated business review. There's a lot more documentation that's provided to me, but I'd like to present you with this information so that you can just see the level of reporting that we are receiving and kind of some of our activity inside of our clinics.
Mrs. Barnes.
I've had several questions from employees referencing the old HRA blood draws that we would have at all the school sites, because that was such a bonus for them, for those that were under our health insurance, to be able to go in to the school within that first 2 hours and have that blood work done. is the Wellness on Wheels taking the place of that activity, or is that something where we're going to go back to in the future with Take Care?
We have not explored having an actual HRA clinic inside of the schools. What we found is when we do that type of scenario, employees would go, they would give their blood, they would get those colorful packets mailed to their home, and that's as far as it went. We did not get the return visits to the clinics the way that program was designed, which is why we have stopped that. We want them to come take an active role of engaging in the clinic so that they do meet with the provider and that they do get that health counseling that they need. Otherwise, at the expense to the county, we are producing them a report that they are either taking somewhere else, which is okay, but we have no way to track and know that, or they are self-diagnosing and relying on their own interpretation of the data, which does not save us any money inside of the health plan. Yes.
Like throughout the course of the year?
Yes, that's what they hope to do. And so they are going to use the response from the DI program to start with those schools. Yeah. Mm-hmm.
Other questions? That's a very comprehensive report filled with a lot of information from which to gauge success or where we need to improve in it. Okay. The next agenda item is to discuss something called employee group waiver, and Mr. Huffman from Cigna is going to tell us about that. Is that correct?
Yes, sir, that's correct.
And you might start by telling them what this is all about. I mean, you have to remind us.
Okay, I'm Paul Huffman with Cigna Healthcare. Melissa asked me to come and walk you through the employer group waiver plan. If you have the little packet that she left in there for you, starting on page 2, what we're going to talk about is strictly dealing with Medicare retirees on Medicare and prescription drug coverage for that group of people. Okay, it's approximately 477 individuals that we're talking about here. Employer group waiver plan is also commonly referred to as EGWIP. So I will use that term. It'll get a smile out of some of you, but it's the common industry term for this. It is not a new concept. CMS created a program several years ago that allows employer sponsors, such as Rutherford County, to contract with pharmacy benefit companies to administer a true Medicare Part D plan. That's not new. Cigna's been delivering that product to several clients ever since the inception of Medicare Part D. What is new is our ability to offer that to clients on a self-funded basis. There are a couple other things that are new due to healthcare reform that are making it more in demand right now, and I'll go through that in just a second. Where you are today, your retirees with Medicare are covered very similarly as your active population. They receive the same prescription drug benefit. They use the same formulary. Their ID cards look the same. Claims go through the same. Cigna achieves the same discounts. Rutherford County gets an incentive or a subsidy from the government called a retiree drug subsidy every year for offering that benefit to Medicare retirees. In 2013, due to healthcare reform, that retiree drug subsidy that's coming back to Rutherford County will become taxable income. So it's not going to be as good of a benefit as it is today. The other thing that healthcare reform brought about is another good piece of information, or a good guy, if you will. If you're familiar with the coverage gap, if you're in Medicare Part D and you don't have any other coverage other than Medicare Part D, there's something that people have called the donut hole. So after they achieve the first level of coverage, they go into a donut hole or a coverage gap where their claims, their prescription drugs, are covered at 0%, okay, and they have to pay for that full cost. Right now, Rutherford County is paying for that, and your Medicare retirees are only paying copays, so there's no impact to them on that. Well, what CMS did, and through healthcare reform, is they're now requiring the pharmaceutical companies to contribute or rebate 50% of any drug, any brand name drug, that is filled while in that coverage gap. 50%. Now, these are the highest cost drugs, and the manufacturers are going to be giving money back at half for that. Now, under the commercial scenario that you're in today, you would not be able to benefit from that. Rutherford County would strictly pay for the full cost in the coverage gap and would forego any manufacturer discounts that were to be had. In addition, like I said, the RDS subsidy is now going to be taxable income. We received at Cigna a huge demand from our municipality and government clients to deliver a Part D administration similar to a plan design you have today on a self-funded basis. Large clients such as yourself who can handle the risk and don't want to go into a fully insured contract with a pharmacy carrier wanted to stay self-funded. So Cigna has developed this EGWIP administration on a self-funded basis, and it will be ready January 1, 2013. The piece that makes it even better is what's called the WRAP, or the supplemental WRAP. That's where Cigna says, we'll administer the Part D plan, but as we know, that's not what you have today. You have co-pays, co-insurance. So Cigna will put a WRAP, a commercial WRAP around the plan that allows Rutherford County to pick up anything that Medicare does not pay, and thereby allowing the members, the retirees, to still only be responsible for their generic copay or their preferred brand coinsurance or non-preferred brand coinsurance. If you'll turn to page 3, this is a very simple, brief example of what I'm talking about. At the top, you see plan design and gap coverage. This is the benefits that you have today for pharmacy coverage for your retirees who have Medicare. The first number is your $5 copay for generics, 20% copay or coinsurance for preferred brands, 35% for non-preferred brands, and then under Medicare, a fourth tier is usually for specialty drugs, and we know those fall under non-preferred brands, so that's also 35%. So let's take an example. Someone is using prescription drugs through the year. They get to what is the coverage gap or the donut hole, and they go and fill a prescription drug that costs $200, and it's a preferred brand. So their cost does not change from what's today. They pay 20% of that cost, $40 under both of these scenarios. Without the coverage gap discount program, Rutherford County will pick up $160 of that claim and pay the rest. But by allowing Rutherford County to partner with an EGWIP, they can take advantage of that coverage gap discount and receive the manufacturer input of $100, thereby lowering what your plan pays to $60. It is a huge advantage, okay, and consequently why we receive so much demand from our municipal clients who have quite a bit of Medicare retiree membership. Page 4, another brief example. We looked at the 477 Medicare retirees that we have covered today. We looked at their pharmacy claims and their scripts and looked at what we would quote on this group if we were quoting on a fully insured basis. If Cigna were to take the risk and allow you to have the exact same benefit but put it on a Part D formulary, have the advantage of the discounts coming back in, we determined that your current costs for these people are about $231 per member per month. With a pharmacy Part D plan with a WRAP, that price lowers to about $170 per member per month. This equates to approximately $350,000 savings on these 477 individuals over a 12-month period. So it's a lot of money to be had. It's something that our clients, such as Rutherford County, are asking a lot about. It's what a lot of consultants are referring to as the low-hanging fruit for those who cover Medicare individuals. I'll walk you through our proposal so you also understand how the mechanics work. If you look at page, or the next page, which I believe is page 5, you don't have to read this. The print is kind of small. What this verifies is for the next 3 years, 2013 all the way to July 2014, consistent with the proposal that we just were awarded, our pharmacy discounts, our pharmacy rebates, pharmacy dispensing fees that we have guaranteed on the commercial side are going to stay the same for this egg whip plus wrap arrangement. Okay, so we're not changing any of the ways Cigna makes money. We're keeping that guarantee in place, and that's what this page verifies. There is no administrative fee for offering this plan. We're not charging an administrative fee for the pharmacy today, and we will not for the egg whip. The next page, page 6. Again, I'll just point out a couple of highlights here. Because you will actually be rolling into a true Medicare Part D plan, it uses Medicare formulary that's approved that we have. There are going to be slight differences, but Medicare also allows you as a client to purchase up buy-ups so that you can keep your benefit levels and the drugs that you cover consistent with what you cover today. This page identifies that roughly 99.8% of the scripts, prescription drugs that are taken by the Medicare individuals today are going to be either included on the Part D formulary or through the buy-up that is included in that cost. So we're capturing virtually 100% of the drugs today. We won't have that problem with something not being covered. Number 2, in the middle of the page, it talks about the positive impact. The only difference is that because we're going to be using a slightly different formulary that is approved by Medicare, there are going to be a few changes where drugs may go from a non-preferred status to a preferred status or to a generic status. What we've determined from the individuals is approximately 69 of those 477 people will see their drugs going to a less costly tier. So from a 35% to a 20% or a 20% to a $5. Okay, that's the good news. Under the negative impact, if you'll skip down to numbers, there's 76 members that will see their prescription drugs go the other way. So they will actually see some of either their generic, not their generics, but their preferred brand drugs that they're paying 20% for today will go up to 35%. They will be notified of that once they fill it, that there is an alternative available, okay? But it's a very close to a wash, the winners and losers. It's not a significant number, but it's something I want to make you aware of. The very last page, if you will, grid that Melissa asked me to include, just to let you know some of our municipal government clients that we are currently or will be administering a prescription drug egg whip plus wrap plan for are listed here. It's approximately 16 clients representing a little over 13,000 customers. One of the second largest is Metro Nashville Public Schools, which I also manage. They were voted and approved to roll this out in January 2013 for their 3,000 Medicare retirees. So some of these clients have been on the books with us under our fully insured arrangement, and a couple of these, just like Metro Nashville Public Schools, will be on the new self-funded arrangement so that you can take advantage of all the manufacturer's discounts and your own claim activity risk. So three things to remember. It keeps your benefits the same. It keeps the retiree benefits the same co-pays and co-insurance. It is a true Medicare Part D plan with its own formulary. That formulary will be available through mycigna.com and in a ton of communication materials. Because it is regulated by Medicare, there's going to be a lot of communication that Medicare requires Cigna to deliver, and we will comply with that. And then number 3, the savings is about $350,000, and primarily that's coming from that manufacturer rebate when those are in that coverage gap.
Mr. Huffman, just a couple of points for the committee as well. You all already administer our retiree pharmacy program today.
Correct.
So it's a continuation of Cigna. It's just how do we pass the claims through the system? The other piece is that under this program, retirees, really the only change that they will see is they have to carry a separate card for pharmacy, correct? So they would receive a separate pharmacy card that they would have to present. And then, are there any other changes that you can think of along that line? Because I think what the committee will be most concerned about is how does this impact our retirees? And ultimately, I think that what I hope for the committee to realize is that it does improve their out-of-pocket costs in some regards, as Mr. Huffman indicated, but it also saves them money eventually on the premiums because we are missing out on these rebates through the manufacturers, which is driving costs inside of the retiree program, and we want to control those costs so that we can offset premium increases in future years as well. So.
Right. So the changes that they would experience, like I mentioned, and I'm glad you reminded me about the ID card. They will receive a new ID card, and it is for those who are entitled to Medicare. Okay, so that's the only people that are eligible. They will carry that. They will use that card. There will be a slightly different formulary. It is a Medicare-approved Part D formulary. It will be on our Cigna website. They will receive plenty of communication identifying that. And then, so one of the changes is that they'll probably see more communication on this than they have in the past, and that is because Medicare requires Cigna, because we're administering it, a true Part D plan, to send out these communications even prior to enrollment, during enrollment, and post-enrollment.
One thing, too, because Mr. Huffman has mentioned the formulary a couple of times, even within our active population, formularies change. So when we do a bid and we accept Cigna or whomever it is, we are really not locked into a formulary. There's a lot of factors that affect what medications are on a formulary, and those can change year over year, and occasionally they'll change mid-year. So it is important to understand that the formulary will be held to the standards of the CMS, but you know, our formulary's actives also change, so I just don't want to overemphasize that role as well.
Okay, so Mr. Huffman and Ms. Stinson, I mean, this is seems to be a win-win situation. What do we do, or when do we do it, and when will this be effective, and what action does this committee need to take?
The effective date would be January the 1st, 2013. We brought it to the committee because it does require that extra card. It does require, you know, I would like for the committee to vote to agree to implement this program or to give their consideration to this program for employees, simply because I think it's better for employees and it's better for Rutherford County as well because of the savings. But we don't want to change and have cards show up at home and have the committee not understand why.
Mr. Sandvig.
This would only apply to Medicare retirees and any future retirees when they hit Medicare age who meet our tiers for coverage and all of that.
Correct.
And Ms. Harvey?
So what we're saying is that you're going to provide this coverage, and then retirees would have to pay an extra premium or amount per month for this coverage, or is this automatically in their insurance premium?
It's in their insurance premium today. What I was talking about when I referenced the premium is we are actually, as Mr. Huffman showed, we are not going to be eligible for that manufacturer rebate that he demonstrated, which lowers the overall cost to the plan. And if we don't take advantage of a program like this, then our plan cost won't be controlled as well as it could be, and all of the plan costs determine what the premiums are. So this is one way to take advantage of controlling the premiums for retirees beginning in 2013.
Okay, and so those people that are already retired that have a Supplement D plan with another company, they would drop that plan and be covered under this plan. Is there going to be any overlap of services do they start January the 1st, all Supplement D plans?
That's a very good question, because that's part of the communication is that you do not need and you cannot go out and buy another Part D. We don't want you to pay the Part D premium to Medicare and buy a plan like that. That's what this is. So if they have that already, I'm not sure why they would, but if they do, and if they purchase this one, the other one would be automatically terminated by Medicare. So Medicare reviews that to make sure there's no overlap. They always do start on January 1, okay? So the key is communication, and that's what we're going to help Rutherford County with.
Currently on that, Rutherford County is picking up the difference, and they only pay the copay anyway during the coverage gap.
Correct.
Right.
Other questions? Oh, yes, all right. Ms. Boney.
Will our rates still go up? I think you may have addressed that, but I couldn't hear you.
The rates for 2013
13,
are already set, so they won't be impacted.
whatever was already impacted, that's the way it's
Right.
going.
That's
And there
correct.
will not be a donut hole, right, to understand? Okay. And how will you notify the retired people? Some of them do not have computers. Through the mail.
Questions? Ms. Nolan.
We still get the discount, what do you call it? Not
RDS? Subsidy?
RDS, subsidy.
No.
We still get that. We don't get that anymore?
No. What happens is because Cigna will administer the entire plan. So you've got money coming from the member when they pay their copay. Then the claim pays from what Medicare gives us. Cigna puts that in your bank account. Then there's the manufacturer rebate. That goes into your bank account. And then Medicare, any subsidy or rebates Medicare has comes back through Cigna, goes into your bank account. So you do get some of it as far as lowering costs, but you do not get to deduct it. It's all part of your total overall cost, and it comes
Right.
back through Cigna.
For us, it being taxable is a non-issue.
True, that's true. For municipalities, it didn't matter anyway. But
Right, so but we still, it comes into our bank account.
correct.
We won't have to submit all those forms every
Correct.
quarter and
You do
ask
not-
if they've been approved, and
And you won't have to get an actuarial attestation on the plan either, because it becomes a Medicare Part D plan.
are there any other questions? Excuse me, Ms. Hickerson.
Not really a question, just mainly a statement. Based on the projected savings of approximately $350,000, to me, it's a no-brainer, so I'll make a motion that we go with this egg wrap or gap or whatever we want to call it and go ahead and forward this on. And to remind it, it's strictly for our retirees. They will get a card that they will use in the mail and not affecting any premium cost as of now, and hopefully reduce it in the future, but I'll make a motion, we approve this.
Okay, we need a second. Mr. Sandvig, any other discussion? Ms. Harvey?
That you are guaranteeing this for 3 years. Is that because that's when Cigna's contract runs out with the county? So
Matching what we offered, yeah.
So is there normally a charge for this?
There is, yes, but we are not charging anything for it.
What percentage of fee would that be to, if you were brand new and you were offering that in like a rebid, what would a normal charge for that to manage this?
Question. I would have to go back to underwriting and obtain that. We knew going into this that we didn't have the ability to charge a fee because we had already committed not to. But I can find out what that would be. I'm sure it's $3, $4 per employee, something like that. That's just a guess.
Okay, any other questions? We have a motion and a second to adopt the plan. We will just call it EGWP. That changes the retiree Part D coverage process. All right, if there's no other questions, all of you in favor of that, please say aye. Aye. Are there any opposed? All right, let the record reflect that. Carried unanimously.
Thank you.
Thank you. That was a good explanation of a somewhat complex process. All right, Ms. Stinson or anyone else other business. I believe that she has at least one item, and you may have some, so tell us what your other business item is then.
We found that there are clerical mistakes on the medical copay option sheet that was handed out. I just want to provide you with the correct copy. This is what you will see inside the enrollment guide as well. It was on the preventative care and the vision, just the way we had collapsed the information. It didn't read consistent with what the benefits were and what our current benefits are. This is more clearly explained, and it is a continuation in both of those categories as to what employees see today. So I just wanted to provide you with the correct sheet for your records.
Okay, so that's just information. No changes have been made in those areas from our current plan, and no changes were planned to be made. Is that correct?
Yes.
Other business from someone else? Mr. Sandvig.
Ms. Stinson, would you go ahead and remind everyone of the re-enrollment dates?
The open enrollment dates are in October this year. We will start mailing out packets to the home on September the 17th. It's October the 1st through the 26th. I hope that ending date's the right one from memory. At noon, and we will communicate that a lot. We are having, as we discussed last time, over 70 meetings this year about the open enrollment and the different medical options. Please send employees, please come to those meetings so that we can help educate you on the new copay option and the other options available.
Okay, anyone else have anything they'd like to discuss? If not, then the meeting is adjourned. Thank you very much.